walk through that in the next 90 minutes here on how we just approach the procedure. But first of all, we got to talk about these. I'd be remiss if I didn't kind of go back to the variables that affect the accuracy of the procedure. And I think the number one thing that I always lead with on this is that first thing, lung volume difference, right? If we don't understand this basic concept of, you know, a preoperative CT scan, right? And then the fact that we are dealing with a volume that is much different. And I say this because if I put a nodule right here, I can't tell you how many times we turn on that first fluoro image and we see the navigation catheter kind of coming down and doing that, right? Something like that, or it's kind of snaked down behind the diaphragm, right? In sulcus, trying to reach that nodule. And I bring this up because we have to remember that on average, there's 1 centimeter in the upper lobe, 2 centimeters in the lower lobe, on average of difference between these two things. And so getting and kissing the electronic target, you know, the virtual target, is not always possible. And don't kill yourself, because the whole idea of this technology is that we're going to integrate the imaging, make the target real, and biopsy the nodule. You know, I think about the way the patient is CT, crooked on the table. Now we put him flat on the table, right? We create, I think about patients' peripheral nodules, patients with emphysema that don't have a lot of lung structure. The idea that we want to just get out there, and what we want to do when we get out there is we want to be very mindful of the fact that sometimes that target, we want to try and put the target, I should say, on the right side of the green ball. Now what I mean by that, or the right side of the catheter. So if we've got the catheter there, we want to try, if we're looking at, you know, the crosshairs, we want to put the green ball on the right side of those crosshairs, at the very least, right? I'm sorry, 3 o'clock. So here's 3 o'clock, here's 9 o'clock, here's 12 o'clock, and here's 6 o'clock, right? So we want to put the green ball as close as we can to 3 o'clock when we're navigating, or off to the right side. If it's straight ahead, that's fine too. But we wouldn't want to leave the green ball way over here. Now, why do I say that? Because if we've got less manipulations, I'm going to talk about like the anatomical changes that we would create additional deformation or movement of the nodule after we do the image. I want you to do the imaging, and as soon as you're done the imaging, the real target is probably right there. Like, you don't see it under fluoro, right? Initially, but it's probably in one of those locations. So you're going to just do the update. Now all we're going to do is pull back the catheter, maybe a little bit of rotation, and we're going to biopsy, right? So we want to set everything up initially at that 3 o'clock position, off to the right side of the crosshair. And then anesthesia changes. These are other things that can really make a big difference. And then let's move into really the beating heart of the platform. That's the integrated imaging. The ability to say, hey, I'm going to image this nodule, and if I image the nodule, I can see the nodule, I'm going to get a diagnosis for that patient. That's really kind of the mindset here with the technology. So those beads are in the board underneath the patient, right? And the whole purpose, the whole primary purpose of those beads is as that C-arm is rotating over the patient, there's a unique geometry created by the angle of those beads, right? They're going to be a little bit smaller on one side, a little bit wider on the other side, and the system reads the geometry of the beads, signs an angle to these pictures that we're taking, and then the pictures are thrown into an algorithm and creates a volume that you see on the right side of the screen, right? That volume is a digital volume. Now, I'm going to draw a picture up here of here's the nodule, and we're looking at this from an axial standpoint, and we're going to see slices like this, right? Coronal slices. That's what you see on the screen there, is a coronal image, right? And you could scroll anterior, you could scroll posterior, but in that volume's 10 centimeters, but in that volume, the center of the volume is the catheter, right? So that's the LG, because where you mark the tip of the catheter, that creates that position of the volume. Now, the real position of the nodule might be right there, might be right there, might be, right there, who knows, right? So all you're gonna do then is scroll a little bit posterior, a little bit anterior. But the point I want to make here is in that volume, and here's the catheter in the center of that 10 centimeter volume. Most of the time, you're only going to be scrolling here. One of the things Dr. Dunn, you and I talked about this yesterday, I think. Maybe you weren't in the room, but we said we would never look for a nodule, down here or up here. Why? Because that would be 5 centimeters away. That'd be too far. The nodule is always going to be, almost always, is going to be just scroll a little bit, one click at a time this way. That's kind of a thing that we teach to is don't scroll fast, scroll quick or slow. Don't scroll fast. A click, 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 click. Each of those clicks is 1.25 millimeters, right? So you can say if I scroll 10 clicks, that's 10 millimeters, right? So you kind of know really quite quickly if where the nodule is. So scroll up here. I said it's crazy how many times I see people looking way down here or way up here for the nodule. It's like you're not anywhere close to it, right? So where you're looking is important. And then the second piece of this is the continuous guidance. Now, what I want to do is the goal here is think of yourself as a sniper, a marksman, an archer. You're looking and you're moving that crosshair. This is what we want to look at. Yes. We want to make that perfect on there. Mm-hmm. And by making that perfect, we are giving our best chance for hitting the nodule, right? Like if you think about it, and Dr. Dunn, I don't think we even talked about this, but if I put a needle out, I do have the video I'm going to show you in a little bit. I showed you this, Dr. Dunn. If we hit a needle right here, the chances are that it kind of deflects off and misses the nodule as possible. If I hit it on the flattest surface, there's a good chance I'm going to access the nodule, right? I mean, it doesn't always happen like that, but there's always that possibility. And this might be the most important thing I tell you this afternoon with your visit here. If you remember one thing when you go to bed at night about our conversation that will make you better at this procedure. You see this number right here? Don't believe that that's the ideal number. You have to be willing to advance or pull back and change that distance. You're the radiologist from inside the chest. You have to be willing to change that distance. I can't tell you how many times we're at 0.5, 0.7, and we pull back to 1.5 and we've got perfect alignment. It's really that easy. That's how easy the procedure can be. Now, if you're
quick question.
Yeah.
I know that this distance is measured from the center
Correct.
of the nodule to the tip of the catheter, right? How do I know that this is coming from the center?
How do you know that?
Yes.
Well, it's the tip of this
Yep.
to the center of the lesion.
The lesions.
Well, I'm just telling you that's what it is.
That's what. Okay. Okay.
No, so
It could be on the side of the lesion, right? Because when the catheter goes in, how do I confirm that this is pointing out to the center of my lesions?
How could you reinforce the reality of that's what's happening?
Exactly.
How could you verify that? Well, the way that you're gonna there's a couple things I'm gonna talk to you about the catheter. So when I have the locatable guide in, it's the distance from the tip of the LG to the center. Yes. Now we know when we do a accuracy test with the system, this is in a static model, we're accurate down to a millimeter. Like it's really that accurate. And we do accuracy tests when we do the install. If a hospital, a physician calls up and says, I think there's some accuracy issues with your system, and you have, we go back and we redo an accuracy test, right? Now, there's a lot of things that affect accuracy though, right? So that number is gonna be accurate as long as you've done everything correctly in the workflow, right? Now, if you're not following some best practices that we're going to talk about today, that number might not be accurate, right? That I think is really the bigger thing. So, for example, let's say that you have a patient that is their lung is de-recruiting. If you've got de-recruitment going on, that nodule is actually moving, but the system wouldn't tell you that. Because we just imaged 5 minutes ago, and now since you had no PEEP or very low PEEP, the nodule is actually drifting away from that position that we imaged at 5 minutes ago, right? So I think that's really probably more applicable to what happens than anything else. If we bring a C-arm in and set it right on top of the patient, all that metal, and we put it right on those yellow sensor triplets, that's going to create an inaccuracy to the system. So the system's going to tell you the green ball's over here, so you're going to try and go to the green ball. The real distance to the target is really further, right? So there's things like that. There's variables that affect accuracy. So as I mentioned, we're looking at that crosshairs. We're going to try and make that perfect. If we remember, we're always trying to put the crosshairs, the green ball at 9 o'clock. So the crosshairs would be here if we're not aligned. And I can't tell you how many times did I say yesterday, Dr. Dunn, make it perfect, right? Make it perfect. Or bring the green ball up to 3 o'clock. So what I mean by that is you always, when you navigate, you want to put the crosshairs, which are the tip of the catheter, and we're always going to put the green ball right at that 3 o'clock as we're navigating and as we're approaching the target. And why? Because as that crosshairs moves closer to the target, this curve wants to go this direction towards the target, right? So if I'm way back here with the catheter, that's my crosshairs. My crosshairs are aimed right here. But as it moves up, as long as I have it at 3 o'clock, it's going to eventually move into the tumor. Again, providing I have the right amount of curve of the catheter, right? That's going to be the piece. Now, usually you guys have too much curve of the catheter, right? That's usually a problem. The physician that was with us yesterday and this morning, he said a lot of times we come up here and we end up like this, right? He says a lot of times the catheter's kind of in that position, and because Dr. Bowling is using a 180 catheter, right? Yes. And so I said, that's fine, but how does Dr. Bowling correct this? How does he make it right? Well, this is the number one concept I want you to remember on how to move the catheter, and this will make a lot of sense as soon as I tell you, because this is what Dr. Bowling does. Part of this I learned from him. The fact that this catheter right here has a curve, right? Yes. If I advance this catheter in one single plane, essentially what I'm doing is I'm building curve. Do you see how that happens? I call that building redundancy, right? I can actually build redundancy in that catheter. If I pull that catheter back very quickly, look what happens. I release redundancy. Yes. So what Dr. Bowling does to get alignment to that target, it's to watch how he moves the catheter. Do you see him move quick? He's quick.
He's quick.
He's quick. And do you know what he does? When he's quick, he goes like this. He's like, boom, and then if you re-advance while you're rotating, you're not building as much redundancy. So all of a sudden, he might not be aligned right here, but by pulling back, releasing the redundancy, re-advancing, maybe to a position that's right here, now he rotates and boom, he aligns. Okay? Does that make sense? But if you move the catheter like a snail, you move it very slowly, watch. When I pull this back slowly, am I really changing the curve? No, but if I pull back fast, I can release the curve. If I rotate really slowly and advance, I'm gonna probably catch and build curve again. But if I can rotate really quick, I can eliminate all that, and now I'm at what I describe as a new pivot point. Okay? So there was a point right here that we would rotate and not align, there's a point right here where we rotate and we align. So if you go back to the same position the second time and rotate, you're going to probably get the same effect. So the point here is we have to pull back and navigate to a different position, maybe a little bit off to the side, then rotate and we align. It's that binary. Make sense?
Makes sense.
Okay, this whole concept of how we move the catheter makes sense?
Yes, it does make sense.
I mean, you get to see Dr. Bowling in action all the time, right?
Yeah. Now, once you go in, right, you put the catheter into your work channel. You take the catheter out. The position of your work channel, does it stay like that all the time, or does it shift a little bit? Or the shift does not really affect anything?
Are you talking about the shift of this LG to the catheter?
Yes.
Yeah, it can change. So there's a tolerance when we design these, build these. That distance can change by a few millimeters and still be within tolerance. So sometimes you might see it like that. Sometimes you might see it like that, right? It can change, and that for the most part, it doesn't matter. It doesn't really affect the procedure. Now, one thing that Ricky's gonna show you when you go back there is you do realize that when the LG is in, all the distances are from the tip of that LG to the center, right?
Yes.
But when we take this out, now it's the catheter to the center.
Yes.
You see the distances are different, right?
Mm-hmm.
But one thing we're going to talk to you about in there that's kind of new that we've been doing for quite a while is if we just unclick this, look at, see, I just unclicked it.
Mm-hmm.
Now you can see they're the same. Mm-hmm. So once I get there, if I make a change and a difference, and I like where I'm at, and I pull this back, nothing changes, right? Because here it's measuring the distance from the tip of the LG to the center of the tumor. Here it's using the sensor. So I just told you a few minutes ago, the number one thing I want you to take away from this is be willing to find the distance that aligns the best.
Yes.
I got two distances that are going to be the same. You won't have to change. How many times do you like pull the LG out, now I got to make another change? Every time.
Yeah, it happens. Yes.
Every time.
Right? So the whole, how do we make this technology hum is based on getting rid of some of these steps. Make it simple. Avoid these steps that really are not necessary. So you pull out there, okay, now I'm making these the same. Now I'm gonna align once, I'm gonna pull this out, give me a tool, I'm gonna biopsy, right? Okay. All right, so next slide here. Let's keep rolling here. So this is the screen setup that you guys employ. You got the whole idea of the alignment. We never want to turn on fluoroscopy until this is perfect, right? Because that would be the incorrect order. It's make it perfect. I got the tool down in the end, fluoro on, biopsy, right? And I know that new people, they want to, let's turn on fluoro. No, can't turn on fluoro until we make it perfect. That's what we want to do. And then we've got this cross-country tracheal access tool. I'm not going to say a lot about this other than the fact that this is a tool that we deployed during navigation use of our microwave ablation technology, our imprint catheter. And what imprint, what we're forced to do is really fully interrogate the tumor with a needle or a wire. In this case, it's a 27 gauge wire at the end of that catheter, and that wire goes out 3 centimeters, and we stick it all the way into the tumor, and then we dilate a track into the tumor, then we put the catheter in the tumor. But look, watch in the video here. This is how you move a catheter. You move a catheter. Why do you move it that way? And this is how we move a catheter down an airway. If I just try and push that in, that's hard. But look at, if I screw it, it goes in easier. We always want to rotate while we're advancing because it goes through the airways, especially in a COPD patient where the airways are very narrow. If you rotate, you can drill, you can get there, right? You can get there. All right. This is our checklist. So, hey, next year, you decide, hey, I'm going to a hospital and I'm going to have access to ILLUMISITE. I want to bring you to Minneapolis for a day and a half, and I want to make you an expert, right? Like you come work with me for a day and a half. We'll have fun, and you're going to go back and you're going to be like, I'm going after everything. Right, and so this is part of what I do. It's a checklist that we run through periodically in training and make sure that every step of the technology you've nailed down. Okay, and then parameters. I'm not going to talk a lot about the parameters right now, but it's really this tree right here, this 3D tree. That is is what we use. It serves two purposes. Number one, that tree is what we use in planning, right? We might have a nodule right here, and we'll click in an airway, click, and then it auto-populates all the way back, right? You've done the planning in their software several times? Okay, good.
We did last time too.
What's that?
Yeah, he does it a lot with me. So.
Yeah, good. And then the second thing is that tree. That tree is what we try and fixate during that automatic registration to create that best fit. If we get the best fit of the seat of the tree on the patient's anatomy, that's just a better roadmap to get to the nodule, right? It's a more accurate roadmap, I should say. It's not going to be any better, but it's going to be more accurate. We're not going to struggle to get over to a tumor because what we see is what we follow, and it's just the truth, right? Okay. So then let's talk about procedure setup. We have this sensing volume. I'll be efficient here with this. We'll get on to some good stuff. But this sensing volume is created around the patient. The sensing volume itself. The only thing, a couple things I want to mention is that if we bring an IV pole up next to that board, we might have to be a little concerned with that, right? That sensing volume does have the ability to be affected, especially if the nodule is really close to that part of the chest. So it's just like, if we can walk between the patient and, let's say, the ILLUMISITE tower or the bronchart, and you got to kind of have everything back anyways to bring the C-arm in. We don't want to put the C-arm right on top of the patient. Those are things that can affect that magnetic field. These patient sensor triplets, sometimes what we do is we bring, especially these two lower ones, we bring those back here posterior, right? And the whole idea there is we bring them posterior, we're not affected by any metal of the C-arm, as an example. So less problem there. As far as all the components here, you feel comfortable putting this on?
I've done it a couple times, but usually they do it for us.
Yeah, most of the time the staff does it, but you just kind of put it on the side and then turn that down. Yep. Okay, so let's see. You got to pull it out, take it off. Okay, so there's a little groove that's created right here, right? Yeah, so bring it on from the side, yeah. There you go, now tighten it down. You got it. Okay, and then to take it off, you got to press the button, and then, and then turn it with the other hand. Nope, you got to press it with one, turn it with the other way, to take it off. There you go, you got it. All right, nice job. But yeah, if the staff ever mess it up, you got it down now. And then we plug the two cables in, right? The one cable, one cable goes to that arrow, the other cable goes to that arrow.
Are they ever going to merge those two cables? Are they ever going to put that so it doesn't has one cable on there?
Well, let's right, if you think about it, we've got two cables, but only for the first less than 10 minutes of the procedure, and then we get rid of one, right? You shouldn't have to put the LG back in.
Okay.
Right? Like less than 10% of the time, you shouldn't have to put the LG. When you put the LG back in, it's when you pull back too far, right? Then you need it to kind of helps you facilitates getting back out.
I was just talking about the wire that wraps around the catheter all the time, so that.
Well, and hey, again, this is a common problem. Like if you rotate, keep rotating the same direction, you're going to wrap it. But ideally, it's you go one way and then you go back the other way. Right? That's how we should be moving this. So you're going to rotate this way, you're going to rotate this way, so nothing should ever wrap. All right? In that instance. So thank you for bringing that up. All right, let's move into what I think is really important, and that is these what I describe as the procedure pillars. Like, how do we build an expert? How do I make you an expert with the platform? Is I've really tried to narrow it down. Like, if you do these 3 things in planning, and you do 3 things in procedure, and you do these, and you understand all of the whys, it'll make for a quicker, more efficient, more effective procedure. So the first thing that I want to bring up here right away is, how many times when you navigate do you not use navigation? Right, we were practicing this yesterday. How many times do you say, I've done my homework in planning, so after I do the registration, I'm not going to look at the ILLUMISITE tower, I'm going to take this catheter down, and I know the subsegment or maybe subsegment to put that catheter down. I want you to challenge yourself in these procedures to not use any navigation and see how close you can put this catheter to the market. And that's what's going to make you good with the platform. Does that make sense?
That makes sense, because usually look at the city, look at all the different plans, and I say, okay, I need to go in this segment, drop it down to the right, so I can just shoot. And then that's how you go in. The last one we did, we go in, and there was, now we will not be close. Then we come back out, use different segment, and now we close. So
okay,
yeah.
But my point being is, if you are in the look at the planning, you perform that virtual drive-through, you understand exactly what segment, what subsegment that you're putting that catheter out. Navigation's only that far, right? I'm talking like a majority of the time it's 3 to 5 centimeters. So if you put that catheter out, now let me even challenge you to take it to the next level. If you put the catheter out and you say, hey, I'm putting it in the airway, but I know once I go into that airway, I'm turning it down as I'm advancing. Now I look at navigation. You can 50% of the time, you can get within 2.5 to 3 centimeters of the nodule without even looking at navigation. You only need navigation a majority of the time to basically, now again, apices, that's a little different, right? Like, that's a longer navigation. Sometimes way down deep, that's a different navigation, right? You might be navigating, 5, 7, 8 centimeters to get to those nodules. But if you know that which airway and what even like secondary turn is there, and you're manipulating the catheter, then you're looking at the navigation platform, that's where I challenge you, right? So take time in the planning, first of all, to understand anatomically where you're going. Catheter curve selection. This is the biggest one. Now, Mark Bowling might be one of the best users of this platform in the world, right? Arguably, yeah. With the number of cases and experiences. Like, really, the difference between you and me with this platform is that, or Dr. Bowling and you, is he's 1,000 mistakes ahead of you, right? Like, that's really the difference. Like, right? Like, he's been there, he's done that. Yeah. He knows how to make it work, right? And that's what like Mark's amazing. But I do think that there's a model, an algorithm that we can use with catheter curves. So we built these catheter curves, and I'll tell you out of the gate that 80% of what we sell is the 90. 80%. So that means 80% of the time you should be using a 90, because the market has talked to us and said that's what we want to use 80% of the time. And I don't think we can argue with that. Now, if we start to put the why behind it, why it's 80% of the time, I think it'll make more sense. Now, what are we doing to determine a catheter? I've given you all these reasons why. I'm not going to go into those today, but it's really this phenomena right here, this nodule to airway relationship. So let me draw you a picture here. I've got an airway, I've got a nodule. In that scenario, sort of being off-road, if I were to take a catheter, I'm going to have better luck in that scenario, and I'm going to exaggerate, a 180 versus something like a 45 or a 90 that might be all the way back here. Now I might be able to get alignment, but I got to come back a long ways. I've got a lot of tissue to go through to get there versus this, right? So I'm going to have this premature capture of tissues and cells, and what I'm putting on the slide isn't going to be always the most desirable. Doesn't mean I still can't get there, but I've got extra step, I've added extra work. I went to this whole discussion here with redundancy and curve that Dr. Bowling, he can do that, and he can do that so quick it doesn't matter to him. And he wants the curve there if he needs the curve, right? But what I'm telling you is that if you wanna do the update, start with the green ball here on the right side, you know, the green ball at 3 o'clock, do the sweep, and all you do is a minor adjustment and a biopsy. Wow, hey now, right? Like that to me can make a difference. So how are we gonna do this? So let's talk through this. So I like this talk track first. So here's the algorithm. So what we're gonna do is we're gonna say, hey, if the nodule is in the center of the airway, each of these lines represent the 45, the 90, and 180. And you can see there's an angle created here, right?
Yes.
So the angle of a 180, angle of a 90, and 45. If we do the planning correctly, we should create an angle on the planning software that will dictate in that last couple of centimeters which catheter curve we should use. Now, I wasn't the only one that came up with this. You know, people like Otis Rickman, they were very instrumental in saying, hey, we have to solve for the problem in that last 2 centimeters, and if we understand the angle of attack in that last couple centimeters, then we'll choose that catheter, right? And so, you know, all of these kind of make sense. Look at where in the 90 where some of the nodules invading the airway or completely tangential again, right? Like does that make sense?
Makes sense, yeah.
Okay, so let's go back and let's experiment and let's talk about some options here. So if we look at this scenario, what we want to make sure we do in planning though, this is mandatory if you're going to do it this way, is you have to make the first click in an airway. You can't just click way back here because you're not creating the proper angle. So you want to scroll and find the airway closest to the nodule, and you're going to make that first click there.
Yep.
You're going to click, 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 and then it auto-populates all the way back, right?
Yes.
So the click has to be as close to the nodule so we can create this angle to replicate the angles I showed you a few minutes ago.
Yes.
You with me?
I see.
All right, so what would that angle represent? Then we have to look at the angle that is the most acute, right? We have to look at the most acute angle. So that would be in the sagittal. So what do you think that is?
I think I would do the coronal. Because
This angle, they're pretty comparable,
Yeah.
but I think that this angle is sharper. It's more acute.
it's more cute, okay.
Yeah, because you want the sharper angle,
Mm-hmm.
right? So the sagittal, although the answer would be the same on both of them.
Okay.
Both of those I'd use a 90, okay? And then this one would be a 45. You with me?
Yeah.
You know what's interesting about this case? This case we were challenged with navigation, and just couldn't get there. But finally stopped, pulled back the catheter. We did a breath hold. We did a breath hold at 20 of PEEP, okay? And we were able to get there right away. We just opened the airways. Like, did a breath hold, held the breath hold, navigated out, and we were there.
So you navigated out during the breath hold?
During the breath hold, right? And it makes sense, right? We expanded some airways, and we were able to get there efficiently. And then we used high PEEP during the procedure to bring the diaphragm down so we could see it. When we were biopsying, we could see it, and it wasn't tucked behind the diaphragm. These are all considerations. So what view should we look at here?
This one, the 180.
Mm-hmm.
Yeah.
Yep, exactly. Yep. 180, we're looking at that sagittal up there. And then this one, I'm gonna give you this one. This one, we think about the scope. The scope is gonna be right here, and there's gonna be hardly any catheter out. This is gonna be all using the scope to point at. So it doesn't really matter because the curve of the catheter will not be extended beyond the tip of the scope.
Okay.
And then this one, 45, right, straight shot?
Yeah.
Yep, straight shot. This one, we could have used a 45, but we actually used a 90. And the whole idea that we could actually, sample more diversely up here or down here, that's what we were granted with this, right? We had the ability to kind of move around into different parts of the actual nodule. And then this one would be a 90 as well, right? So if I think about, you put the nodule up here, it's going to be a 90. Put the nodule here, 90. But if I put it over here, it's a 180. Now, why? Why is it a 180? Because when we're advancing, everything wants to be pushed. Axial forces want to be pushed this direction. And if we can bring it around and point those axial, or use the curve of the catheter to point more medial, that's where a 180 is going to help us, especially on those medial. Anytime we're going medial and we're back to this tangential scenario, we're going to be better served with a 180. And then the last one here, I like this example because this was one where we went with a 90, but we got out there and we were kind of pointed all around it. And what we did is we went past the nodule, put a tool in, rotated, and then pulled back. Now you come back too far, you're going to get this. But we just pulled back, we released the redundancy of the catheter by pulling back, and we biopsied, right? So think about that. Let me go past the nodule, rotate against it, and drag back. I was in a case that was clearly a 90 or 45 not so long ago, and they had used all those up, but all they had was 180s. And I said, come on. So that's what we did. And we got the diagnosis. We went past it, we kind of navigate, and then we just drag back on top of it. And sure enough, we were successful. All right. So again, why is the catheter so important? If I'm right there, I can just put a biopsy tool in and biopsy, right? I don't have to worry about all these manipulations. It just is center straight, and I think you'll see more of that today when you go back with Ricky. All right, so we talked about that. Here, I think these slides, again, this is kind of what I told you at the beginning. This whole idea with distance, right? So if I've got a nodule that is, can you see? This would be a 90 catheter. Look at the different positions. The one on the far left is not aligned. The one in the middle is perfectly aligned with the 90 catheter, but if I'm too close, I might not be able to make that perfect. But on the image on the far right, if I'm pulling that back, I'm going to get perfect alignment. Now this might be a slide, Dr. Ben, that we add to the talk if we think about distance optimizes alignment, right? So we could get rid of the two red lines there and just hold the black one and say, hey, look what happens with optimal alignment. Optimal alignment, we center strike the tumor, right? So, picture one on the left would be too far away. Picture three would be too close. Picture 3 in the middle would be optimal alignment once you achieve the optimal distance, right? That's kind of what I would see there. All right. Okay, so let's move on to obviating or eliminating pneumothoraces a majority of the time.
Yes.
Right? This is my background was in interventional cardiology, interventional radiology. My world was imaging before I came to Medtronic to work in the lung space. But I told you when we got to 2018, we integrated the imaging. Oh my gosh, all of a sudden I'm back home, right? I'm back home with the imaging. Ricky's the imaging guy too, so we really enjoy the banter, the opportunity that imaging creates. And part of that is you have a C-arm there, and you're now performing the biopsy, so we really want to optimize the position of the C-arm. Now, 3 opportunities that come from angling the C-arm. Number one is we can, by angling, so C-arm, if we optimize the position of the C-arm, we'll, number one, see more nodules. Okay, why? Why do we see more nodules? Well, this is actually pretty simple. If I've got CT scan here, and I've got a nodule, like the picture shows here, right? and I've got the image intensifier, X-ray tube below, X-rays come up this way. I'm going through tons of clutter right there. But if I can angle the C-arm, in this case it would be to the REO, so right anterior oblique is moving it to the right side, the image intensifier. If I move that image intensifier to the left side, it's left anterior oblique. And so if I move the C-arm over to here, now I am eliminating some of that clutter, right? Some of the imaging clutter is moved out of the way. So by moving it to that oblique angle, I may now be able to better visualize the nodule. One suggestion I make all the time is that when you guys are doing the sweep, I want you to focus on looking for the nodule. And if you see the nodule, put the C-arm back to that angle, right? You'll see the nodule majority of the time. You will. Now, the other thing on the list here is, and this is most important, it reflects back on perhaps, possibly, your incident is pleural boundary, right? You, 100% of the time on pleural-based nodules, and it trumps everything else, you need to identify that pleural boundary. So if I stay in AP and I put a needle out, so I got my catheter coming this way, I put a needle out, theoretically, I have to put a needle all the way to this point radiographically to determine that I've violated the pleura.
Yes.
Would you agree with that? Does that make sense?
It makes sense.
Okay. Because this is the pleura I would be looking at radiographically.
Mm-hmm.
You need to radiographically identify that pleura, right? Every time. You have to say, what angle does the C-arm need to be in? If I've got a nodule right here, the C-arm needs to be like this, right? It needs to be REO. If I've got a nodule right here, right where this one is, I've got to put the C-arm to that angle. I've got to put the C-arm to that angle. I've got to put the C-arm even to that angle. Make sense? Mm-hmm. So maybe 5, 10 degrees LEO, 25, 35, right? If I have the nodule right here,
Mm-hmm.
where am I going to put the C-arm? REO or LEO?
Hello.
REO. Okay? Make sense?
Why you have to go cross?
Well, because we want to see that pleural boundary right there. So the C-arm needs to be right here. X-rays need to come up, because a lot of times your catheter would come around, and that's where your tool's coming out. That's where you give the pneumo, right?
Yes.
So if the nodule is right here, to get there, you're coming in like this. So you need to understand that pleural boundary right here. And with this, a majority of the time, comes the opportunity to see profile, right? Look at this, profile, not this. Is this what happens? I don't know how far my tools are going out. Do you see how far my tools are going out now? Right?
Yes.
Okay. So if I put the nodule right here, which way am I going to angle? REO or LEO?
Oh, that'll be LO.
Okay, right here.
Yeah.
So I'm gonna REO.
So the
Right?
all right. I'm looking at like on one side I'll accidentally or there's a potential chance that I can reach the pleura. Right? That's what I'm looking at.
Yeah.
And if the nodule is on the right,
Right here?
the place you were before. Go
Up here?
Yes.
Okay.
If the nodule is on right there, the closest pleura I'm gonna get to
Is right here.
is right there.
Yep, and that's why this is gonna show you it the best, right? So you might not, I can't put the C-arm at 90 degrees,
Okay.
right? So the 90 degrees would be perfect, but that's not practical. So what I get by coming to REO is I get better profile. I want the catheter, if this is the catheter, right? I want the X-rays to be perpendicular to the catheter, if I could.
Okay.
But if possible, I want to understand the pleural boundary. I want the X-rays. I want this ray right here, this coming up. I want that to be parallel to the pleura, right? So this is the X-ray coming up, and I want it as close to parallel as possible.
Parallel to pleura, okay. If you have a nodule, like we were here earlier, I'm concerned about this pleura.
Yeah, that's right. So that's why we want the central ray parallel to the pleura. We want it perpendicular to the catheter, right? Those are the two things that we're trying to do: perpendicular to the catheter, but parallel to the pleura.
Okay.
Make sense, Dr. Dunn? Any questions? Okay. So if we put it right here, now I'll tell you, you can't biopsy this here. We can't do this, right? That's like impossible almost. But if you are in any of these, like if you're right here, that's going to be probably AP, right? Like, but I would still, again, I would still rotate here so I have an idea of my tools coming out, right? You would want that when you're possible, because you're not going to be coming in like this.
Yes.
You're going to be coming in like, here's the airway. It's going to be something like this. You can't go at 90 degrees and puncture the aorta. Hey, I came from the world. We punctured the aorta. We accessed through a translumbar approach for angiography. We put patients on their stomach and we punctured the aorta. Right? That's how we did angiography in the early days.
Wow.
Right? So that ages me. They don't do that anymore, but this was in the cowboy days. It was even a little after the cowboy days, so to speak. All right. Does that make sense?
Yeah, it makes sense.
Do you think in that case you described, this kind of methodology would have helped at all?
I think so.
Okay, good. I like to say maybe, right?
What was me and Tito Brown? We were like,
Was that the one with the pneumothorax?
yeah. Yes.
Sorry.
What's that?
Nothing.
Okay. All right. Well, good. Well, like, hey, if I can impart my thoughts on this, I know it makes a difference because we can see the nodule and we can see the pleural boundary and then see our tools, right? And rebus. If we can put rebus in profile, we can establish a biopsy zone. We can establish where it's concentric. What Dr. Dunn does is he takes a little mouse, puts a little mouse like cursor, like that's where pointed at the nodule, right? Like that's where I want to biopsy on the fluoro. Make sense? Okay, all right, so that's all the reasons. Now I want to take this a step further. This is kind of advanced angling. So if we think about all these positions, and this correlates to the beam being parallel to the pleural boundary, right? Every time, that's what we're doing. I'm going to take this one step further, and I'm going to talk to you about using the nodule by looking at a sagittal scan, right? So you've got sagittal in your planning, you've got sagittal in the procedure, but let's say we have a nodule right here. If we put the X-ray tube here, or image intensifier X-ray, we fire through, we're never going to see anything because we're going through the diaphragm. In this case, we'll move the C-arm towards the head, cranial. Now we're X-raying and we're peeking underneath the diaphragm. Or if you put the nodule there, we're going to move the C-arm caudal, and we're going to peek above the diaphragm. Make sense?
Makes sense.
Right? So think about, we're not limited to just RAO or LAO. We may want to move the C-arm towards the head or towards the feet to get a projection that will give us something so we can see what's coming out the tip of the catheter. Now, take that one step further. If we've got a nodule that is, let's say, in the coronal view in the sulcus here, but yet it's back here, right? It's someplace like right in here, but back in the sulcus. Actually, it'd be like right in here, right? So we can put a little bit of areal and cranial. You can do both angles, right? You can do both angles for it as well. All right, let's move on to what is the most, I believe, is the most important topic. So let's review, first of all, planning. We talked about doing the planning, understanding our anatomy.
Right CT. We should have the right CT chest.
Right, CT parameters, exactly, there you go. But I think the pillars, as I talked about before, anatomically, use your white light to get to the nodule.
Yes.
Challenge yourself to get close to that virtual target before you finish off the simple navigation. And then secondly, choose the right catheter, right? Again, Dr. Bowling is the exception, right? Exception to the rule here. And then the third thing is the C-arm. Start to think about it in planning. If we're thinking about it in planning, it might translate to like, hey, I analyze that in planning. I know it's REO, right? And you don't have to guess in the procedure. The other thing that you can do is at the beginning, do you know when you mark the catheter tip at the beginning of, after you do the sweep, you mark the catheter tip twice? You can look at those two images. You can say, hey, that one's better profile. I like that view. I'm gonna move it closer to the beginning of the sweep, right? So there's other little tips and tricks that we'll share with you. Okay, so let's move on to our procedure pillars. I think that this one is probably the biggest, the most impactful to the procedure from so many points of view, and that's anesthesia. If we are not keeping the lung recruited, we can have challenges. So 3 reasons why we want to instill some sort of anesthesia best practice. Number 1, we want to see the nodule under 2D fluoro, right? If we can see it under 2D fluoro, that's a confidence booster. Like you're just talking about that 8mm one, right? You saw it. You saw the nodule under 2D fluoro when you angled the C-arm. Remember, we just got done talking about why we angle the C-arm. We angle the C-arm so we can see the nodule, right? That's part of the reason we angle. But if you can see the nodule, what makes the nodule possible to see is if I take 2 nodules, right? And I have one with recruited airspace around it, and I've got one with de-recruited airspace. It's this tissue contrast difference is what allows me to see the nodule. Make sense? Right? Just like seeing a bone and soft tissue, right? Like we have a contrast difference. So the same thing applies to digital tomosynthesis. Recruited airspace, de-recruited airspace. Nitrogen splint, no nitrogen splint, right? So what do we want to do? Well, we'll talk about it. So first of all, we want to see the nodule with anesthesia. Secondly, navigate easier, right? If the lungs, if the airways are inflated, it's easier to navigate. I think back to 2010, 2012. I was out supporting these cases, and they turned to me like, any ideas? We're 4 or 5 centimeters away from the nodule, the green ball. We couldn't get there. We couldn't get there. And the reason we couldn't get there is because there was complete collapse of the airways, and where there's no way we were going to get there. And the idea should have been, had I been smarter, it took me till 2018 to realize this, is I should have said, hey, can we recruit the lung? That lung is de-recruited in that area. Navigation's easier. The step 3 here, I think this is not as big a one, but it's really offset of the registration. So what I mean by that is at the beginning of the procedure, you're creating a best fit. You've got the CT scan, you've got the patient anatomy, you're laying those together to get the best fit, but then all of a sudden your navigation, it's like, God, it doesn't match. It doesn't look as like I'm really there. And so having a good registration makes that easier. Okay? So all of those reasons. So what are we kind of, as a general guideline, what are we kind of talking about here? Well, the first thing we want to do is we want to lower FiO2 to 40 to 60%, lowest tolerable. Right? Now, why? Because the second step here is we're going to recruit. And it might be 30 millimeters of water pressure for 30 seconds. It might be 40 millimeters of water for 40 seconds. Now, by doing this, we're gonna force the nitrogen splint. Like if you look at this picture right here, this is real. This is what happens. Like, think about it. Any part of this posterior half of the lung could be difficult to visualize any nodule with tomosynthesis. We have to recruit the lung to get that back to look like the anterior portion of the lung. And that can only happen with these recruitment maneuvers. And then the third thing is PEEP, right? 8 to 10 upper, 12 to 15 lower. Patient safety always first, right? We can also assess hemodynamic instability, right? I'll pause right there. Any questions? Make sense?
That makes sense.
Okay. All right. So now what I want to do is I want to talk about breath hold, because these guys were informing me yesterday that anesthesia doesn't always get this right. Do you have to take a call?
No.
Go ahead if you do.
No, it's good.
Okay. So what I want to do here now is I want to talk about the breath hold, and here's a picture that kind of speaks to that. If we think about that tidal volume breath hold, this is our PEEP. You with me?
Mm-hmm.
This is our peak airway pressure. So let's say we're at 10 here. Let's say we're at 35 here. We want to do a breath hold somewhere between these two.
Yes.
Why? Because this is where we're navigating. This is where we're biopsying. We wouldn't want to image the lung and take a picture up here, but then biopsy down here later. So when they grab the reservoir bag, we know factually that this happens. And here's a picture of that, right? In the background, we're filming or we're recording. This is tidal breathing, and this is the diaphragm coming down. This is the breath hold, and the imaging's taking place, and then the patient goes back to tidal volume. So we've imaged the nodule here.
Yeah.
We're now biopsying here. Let me say it another way. If the nodule's here and they do a bag squeeze, it's plausible or probable that nodule is going to come down with the diaphragm. I'm going to image there,
Yeah.
but now they go back to tidal breathing. So now I update my navigation. I'm going to navigate down to this target here. But the nodule's up here. I'm going to miss the nodule. And I've seen multiple examples of that where they're non-diagnostic studies because the wrong breath hold was done. Any questions?
That makes sense. So you think there should be, when we do the breath hold, we should find the phase of the breath hold and do the biopsy at that phase?
No.
Match?
No.
Because when you do the breath hold, if the
Why don't you just do another breath hold? People are doing 6-minute, 20-minute, 27-minute breath holds out there.
okay.
If you
Right.
want to, rather than try and time the phase, just go back to another breath hold. If you've got a small nodule on the diaphragm, 8 millimeters, all you do is turn up that gas inflow, okay, turn it up from, let's say 3 liters per minute, turn it up to 8 to 10 liters per minute, so you got more oxygen. It's just it's a CPAP hold.
Yeah.
That's all it is.
Yeah.
And the patients will tolerate it at 40-60%. Now, what they're doing at Vanderbilt, and I'm gonna hook your partner up with the Vanderbilt people, because I want him to have a discussion on this. He's good with ventilators and stuff, right?
Have you already gone?
Yeah. So I want him, and I'd love to get in on the discussions on this. I want to put these guys together and say, hey, what they're doing at Vanderbilt is they're going back to 100% oxygen, and they're doing these breath holds for 23, 27 minutes.
Wow.
Yeah, all the while they biopsy, and then they're finishing their biopsy. So where they imaged it is where the patient stays for the next 20 minutes while they biopsy. Right? Nothing moves. Nothing is moved.
That's pretty much my question, because if things are moving,
Yeah, but here's the reality. Things are going to move more if you're not using high PEEP. If you're using high PEEP, things don't move that much, right?
I think he's talking about when you do the APL breath hold during the sweep, why not
Mhm.
biopsy at that breath hold? I think that's what
And
he's
that's,
saying.
you can do that. You should do that.
Yeah.
There's nothing wrong with that. In small nodules,
Mhm.
so there's two things that we can correct for. We can turn this right here. And I'll tell you, Vanderbilt's pretty much standard. They're using 15 a PEEP on almost everybody at Vanderbilt. I want to get you on this call too, so you can hear what they're doing, right? Because if we're using higher PEEP, we might be, right? You with me? So here's 15 a PEEP. This variation is going to be less than this,
Yes.
right? So I believe that that's an easier way to solve for movement,
Yeah.
because I'll show you this. Let me show you this picture here. Do I have this in this deck? I don't think I got it in this deck. Oh, Dr. Dunn, you're gonna love this. This is a full procedure. I'll let you watch this while we're talking. This is what I'm talking about doing. This is a video I made of an entire procedure. This was a patient with a 54-year-old with an exophytic mass in his left humerus. The CT scanning showed this nodule adjacent to the rib. Radiology would not biopsy this. They didn't think they could hit it. So we do a ILLUMISITE procedure, and this is just the whole workflow showing what was possible with the technology. And so you do the registration, you get the best fit. Look at that little tiny guy out there, right? So then navigate down. Again, you're just going after the target. It wasn't the best CT scan, but again, we just follow out there, get into the vicinity of it. We don't make it perfect. And now we launch local registration. And then watch, look at how far. That was like a minute of the video, less than a minute, right? So now we're gonna launch local registration and move through the workflow, right? So we bring up the first screen, and I kind of go through these kind of fast in the video. We bring the C-arm in perpendicular to the patient. We then we select head and left. I had to get rid of all the patient identifier stuff on this one, so I had to get rid of all that stuff. We center the C-arm above the patient. We move the circle over the tip of the catheter, and it's at this point we're going to then rotate the C-arm we move the C-arm to the starting point, and then here's where we initiate a tidal volume breath hold, and we do the sweep, right? Now in this one you can actually see the nodule. Not here in the video on my laptop. I can actually see the nodule for part of the sweep. It's kind of crazy that you can actually see that tiny nodule, but it's because he had a strong ventilation protocol. So here we mark the catheter tip. You see how fast we're running through the workflow? By just kind of condensing the screens, because right away, boom, we click it, we go to the next screen. See how I just fast forward that? And then now we're in the digital volume. There's the nodule in the lower right side of the picture, and we update it. And then we mark it a couple more times, again at the beginning and end. And I just take a lot of the time out that it takes to do this and kind of move through the video. And now we get this video playback, we get this update, and voila, catheter position updated. Now we go on to the biopsy, right? So he's decoupled in the lower right-hand corner. But watch in the fluoro. We started with a brush on this one. So what's amazing about this is we see the rib, but we're targeting the medial aspect of the nodule, right? So right here we're targeting, and he puts a brush out because he didn't want to, create an injury. Brush was negative. So then he goes with a needle, all right? So now takes a needle, puts a needle out, again, targeting the medial aspect. Here's the needle right here. You see a needle going out, but he's more or less on the medial aspect. First pass with the needle got the diagnosis, sarcoma.
Wow.
All right. Anyways, I didn't mean to sidetrack you. I was looking for an image there.
That was really good. Thank you.
That's good.
All right. So we were talking about breath holds, right?
Mm-hmm.
And I guess my first choice right now, because I don't know enough, I can't speak to the safety, efficacy of these long breath holds. I want to learn more, but I can't be suggesting that because I don't have any data. I think they're looking at doing a study, and it might be something that you guys would even partner with them on the study, especially with his experience with ventilators.
Absolutely.
It might be worth collaborating. But I think for now, if you up the PEEP, you're gonna have less movement,
Yes.
right? I think if you do a short breath hold, 3 to 5 minutes, turn up that fresh gas inflow at that same breath hold, that same APL setting, right? You're gonna be pushing oxygen into the lung.
Yeah.
You're just gonna have a stable lung and it's not gonna move at all. All right. The next phase of what I want to talk about here is really, and all I have left to wrap this up is the automatic registration, and you're going to go back and do this. We have a best practice. We are just coming up. We have 15 minutes. We're going to swap. If we talk about today's registration is based on how well you fit the CT scan on top of the patient. You do that through driving through the airways, right? And then what happens behind the scenes with the algorithm is you get this flexion, right? You get, so think about it. When you're doing a CT scan, patient takes a breath in, right? Now at the time of the procedure, the lungs sort of rest, or they fall back into a slightly different position. That's what we're doing here. We're flexing the tree. That tree flexes to align with the anatomical airways, right? So this is essentially the old Super D, but once we apply the enhanced registration, we get a better alignment to the CT scan. Now, I'm going to go through this video because I want you to see. This is kind of I call it the best practice that we are suggesting during the registration. And if we hit the button here, the start button, think of it as 3 districts, right? We're going to first register the trachea. So watch what I do in the trachea. I come all the way up and all the way down. And I actually did it twice here, right? And then we go to upper lobe. Target is in the left lower lobe anterior segment, okay? So we hit upper lobe, we hit middle lobe, and we hit lower lobe. Go into the airways that are easily accessible. Don't kill yourself, right? Don't fight it. 15 seconds maybe. Now we're in the left upper lobe. And again, I hit lingula here, so there's superior lingula, and I'm gonna hit anterior segment. You don't have to go deep, it doesn't matter. It really doesn't matter. Now, I'm gonna go into lateral segment here first, and now I'm pulling back, and I'm gonna park in front of that anterior segment. Now I'm gonna go ahead, put the catheter out once, I'm gonna pull it back, I'm gonna put the catheter out a second time. Voila. Now, what we're gonna do is we're gonna bring up this registration review. I'm gonna hit done, and this registration review will come up. And we're gonna actually hit it right here, registration review. And then we have this tree that comes up, and all I'm looking at, all I care about is this. All I care about is the lower lobe. And what I want you to do when you do the registration is I want you to use the bronchoscope. I don't want you to look at check marks. Check marks don't matter, because you've seen the check marks come and go. They come and then they go and then they come. And then sometimes you're like, I gotta go back and get that check mark. No, you don't. No. If you only have one check mark on the right side, it doesn't matter. Remember, I just told you there's 3 districts. It's an individual lung registration. That's all you gotta know. All right. Questions on that?
No, that sounds good.
All right. And now all you're gonna do is, because again, you're gonna accept the other thing we can do is use your scope, touch the catheter right there on the carina. Does the target here, the virtual, match reality? That's the other thing we can do. We wouldn't want to come all the way back to the main carina and do that. People used to do that. It was a bad idea. We want to we want to go down and touch the carina right there and then navigate the rest of the way. All right. Let's show you one or two more things and then we'll flip here. Take 5 minutes and I got to run to the bathroom. One thing Ricky's going to talk to you about is this concept of isocenter. If we look at the two images here, the image on the left is what we call an AP sweep. The image on the right is a asymmetric sweep. Okay? So, you don't really see the nodule here on the left, would you agree?
I don't see it.
Okay, but look at the image on the right. Same patient, just two different sweeps. Right?
Yep.
Night and day.
Yep.
The reality of it is, the nodule's right here. But you see it better over here. Do you know why? So the nodule, go ahead.
This is we're looking at a 3D image right now.
Yeah, this is a
2D, I'm sorry.
It's a 3D volume because I can scroll through it, right? It's a volume that's three-dimensional. But the reason, the why you can see it on the image on the right is because of how we are angling the C-arm, how we're approaching the nodule. So when you do a tomo sweep, so here's a nodule. In this case, the nodule was positioned right below the aorta. Okay, and the nodule is right in here. So when we did our, and I'm going to say 0 degrees is AP with the C-arm, right? And we rotated 25 degrees LAO to 25 degrees RAO, okay? And remember over here, I said, hey, we get these slices that kind of scroll like that. We scroll through and we see the images. So what you would get here then, when it was time to look at these images, is you're going to get slices that look like this, right? The problem with it is there's a volume averaging effect that takes place where it adds slices here with the aorta. These volume average together versus a asymmetric sweep where we would sweep 35 to 40 degrees LAO to 15 degrees RAO. Now we're coming in mostly this way and we're slicing this way. And there's air above and below the nodule. Does that make sense? So we don't get a volume effect with air versus the aorta. Make sense? So if you wanted to make this your standard practice pattern moving forward, anytime you've got a nodule that is adjacent to the pleura, there is a benefit to say, I don't want to slice it in an AP. Why? Because I'm going to get a volume effect with the pleural boundary versus a effect of doing an asymmetric sweep. Again, in this scenario, mostly to the left side because I've got air above and below the nodule. Okay? Does that make sense? And this is one of the things that we talk about, like how do you, tips and tricks on making the technology really hum. This is a big part of it. It's actually, if we think about how do we see nodules with a very strong percentage of the time, number one, it's anesthesia. Number two, it's asymmetric sweeps. Number three, it's really something that's described as isocenter. Does that make sense? Do you know what isocenter is? Operating the sweep with the nodule in an isocentric position. So here's the phenomenon. Okay, so if I put that nodule or the catheter at the midway point, between the image intensifier and the X-ray tube. No matter which way I sweep, when I look over on that fluoro monitor, it needs to be in the center of the screen. That means I'm at isocenter. If I'm not at isocenter, look what happens. As I sweep, I might be at isocenter in AP, but as I move to REL, look at what I'm imaging through. I'm imaging through the spine. It's gonna say, X-ray system, give me more X-ray because I've got to penetrate that spine. And for part of the sweep, it's going to burn out the nodule. So now I'm not optimized the imaging throughout the entirety of the sweep. The energy level that I need needs to be optimal throughout all the angles of that 50-degree sweep. If they're not optimal, I'm going to either under-penetrate it or over-penetrate it, and I may not see the nodule as well. Okay? All right, I'm going to give you a break.
That makes sense.
So these are the top 3 imaging things. Anesthesia, asymmetric sweeps, and operating at isocenter. And there's a couple other things, but...
An asymmetrical sweep, so you said pleural nodule with one. What would be another reason to do an asymmetrical sweep?
Anytime it's abutting mediastinal tissue, the spine, the heart, anything, yeah. Anytime we've got something where the nodule is abutting. So remember that picture that we had back there with the C-arm? Like, let me go back to this one here, right? These C-arm pictures. I'll bring it back here. Okay, so if we've got a nodule that's right here, if I put a nodule right here, if I do an AP sweep, 25-25, it's gonna blend in this. But if I do an asymmetric sweep from here to here, and I image, and I'm giving you slices like this, it's gonna have air above and below, right? If I put a nodule right here, I'm gonna do an asymmetric sweep to the right side because I wanna slice like this so I can potentially put air above and below the nodule. If I'm imaging a nodule, we just had this underneath the aorta. We had to go like this for the aorta, right? But if you put it down here, it's going to be asymmetric this way. If you put the nodule here, it's going to be asymmetric this way. Anytime you can put the 0 angle of the C-arm and put air above and below the nodule, you will see the nodule better.
Close to the diaphragm, would that be one as well?
Well, yeah. Well, so let's talk about that. So we're close to the diaphragm. So it depends. Like, where do you want to put it on the diaphragm? If it's on top of the diaphragm, it doesn't matter, right? Like if it's on the dome of the diaphragm, it doesn't matter. But if you put it in the sulcus of the diaphragm back here, posterior, I would be doing asymmetric this way. If it's posterior in the sulcus here, I'd be doing asymmetric this way, right? Because now you can put in the 0 degree of that sweep, you're putting air above and below it.
Makes sense.
Does that make sense?
Makes sense. Just gotta do a little bit and see.
You got to do it. And here's where I suggest you start. Start with angling the C-arm. And if you say, hey, I see, because this is really the telltale how to do this. If I go back to where I had the angle for biopsy, like where would I put the C-arm for angle of biopsy? That's your 0 of the sweep, right? So if you're going to say for this one, I'm going to biopsy with the C-arm in the REO position, this is going to be an asymmetric sweep to the right. If the nodule is right here, this is going to be an asymmetric sweep mostly on the left. It's a crossover concept most of the time.
Makes sense.
Yeah.
Got it.
Good.
Yeah. So first practice on the, like your thought process on the biopsy piece. Like, how do I understand the pleural boundary? If you understand the pleural boundary, that's what this is about. Asymmetric sweeps are about the pleural boundary.
Ms. Son, they're actually going to give us a model or let us borrow a model so we can do practice in any time we want.
Okay.
Maybe we'll do that like the 4 cases and
Yeah.
those kind of things. Like a simulator.
Yes.
We're gonna
Simulation, yeah.
It's simulation. We're going to have the lung model so
Oh, yes.
we can have it hooked up.
Yeah, we're going to get one for you guys to